And how do you integrate different risk calculators into decision making around lipid lowering intensity?
Yeah, so that's a really good question. I think that this is really for patients who we're talking about primary prevention, because once somebody's had a heart attack, once someone has peripheral artery disease, or if they've had a coronary calcium score that is elevated, at that point we really need to have them on medications, and there's really no question of whether or not the medications are indicated. However, for patients who maybe have not had any history of heart disease, but maybe they have risk factors, including family history, or if they have diabetes, hypertension, obesity, metabolic syndrome, those are the folks where we'll do a risk calculation and we'll try to determine whether or not they need to be on a lipid lowering therapy. And usually, what the answer comes down to is how intensive their statin dose should be. For folks, if we put in their numbers and find that their risks are low or intermediate, then we start to think about other ways that we can essentially convince ourselves whether or not they need to be on lipid lowering therapy. And so that might incorporate use of screening tools like a coronary calcium scan, or even stress testing, depending on if someone has symptoms or not.
Hmm. And how have updated endocrine and diabetes society recommendations influenced your thresholds and targets for lipid therapy in patients with diabetes?
Yeah, so for folks who have metabolic syndrome, diabetes, obesity, hypertension, they are in a high risk category. And sometimes when we plug their numbers into a risk score calculator, we may not find that their risk is actually high compared to our clinically suspected risk. And usually, what that has to do with is their blood pressure and their age. So for our younger patients, we are less inclined to treat them with lipid lowering because their age just doesn't put them at that category of being elevated. For those patients, there's a number of different things that I might consider. Again, talking about lifestyle modification and preventing heart disease, weight loss through physical activity and heart healthy diet. Those are things that I pretty much talk to all of my patients about, but I try to be a little bit more encouraging for patients who have metabolic syndrome. Another thing that I'll consider is thinking more about weight loss. So, GLP-1 agonists are very hot right now, but for very good reason, because we know that by losing weight, by getting into a lower weight category, a lower BMI, that we're able to mitigate so many devastating effects that obesity can cause. And so a lot of times I'll work with my primary care colleagues, I'll work with my endocrine colleagues, weight loss specialists and nutritionists to think about medications like GLP-1 agonists. And then in addition, in my patients who have diabetes and are at risk for kidney disease, or if they have some screening tests that come back that show some kidney damage. And so by that, I mean a creatinine or cystatin C or a urine albumin creatinine ratio. If any of those things are flagging as a little bit elevated, those are the folks that I'm more aggressive about getting them on SGLT1 inhibitors. And so, trying to prevent the development of renal disease or diastolic dysfunction.